Hi, I'm Megan, and welcome to the Girl Talk podcast. Pregnancy is often spoken about as a time of joy, but for many, it can also be a time of loss, confusion, and a quiet grief that isn't talked about enough. Today, we're opening up on the difficult conversation on miscarriage, what it is, why it happens, and how to navigate both the physical as well as the emotional aspects of this experience. To guide us through this conversation, I'm very glad to welcome Prof. Devendra, our expert for today. And this episode is just dedicated to who has gone through a miscarriage, who is currently navigating it, or supporting anyone who is. Allow me now to introduce our guest today, Prof. Devendra. Adjunct Associate Professor Devendra Kanagalingam is a senior consultant with the Department of Obstetrics and Gynecology and lead clinician for the delivery suite at the Singapore General Hospital. He graduated from the National University of Singapore before continuing his postgraduate studies to become a fellow at the Royal College of Obstetrics and Gynecology. As a recipient of the Public Sector Transformation Award 2025, Exemplar Professional Clinician Award at the Singapore Health Quality Service Awards 2025, and other numerous faculty and teaching awards, Prof. Dave is known for his approachability and dedication to his patients and mentees alike. He has a clinical interest in the management of high-risk pregnancies and the care of women in labour, and has published several clinical research papers in peer-reviewed journals surrounding such topics. So hi, Prof. Dave, how are you doing today?
Hi, Megan. Thank you for that very kind introduction.
Yeah, Prof, I think today we're hoping to navigate a conversation that is difficult, but all too important. I was just wondering if maybe we could get straight into it.
Sure.
To our listeners who may be less familiar, what exactly is a miscarriage?
So from the medical point of view, we use the term miscarriage when somebody has lost a pregnancy prior to 24 weeks.
Mm-hmm.
And 24 weeks is taken as a cutoff because it's when we know that babies can start to survive outside the womb after 24 weeks.
And because there are many terms that are thrown about. How does a miscarriage differ from something like a chemical pregnancy, abortion, or even something like a stillbirth?
A chemical pregnancy is a special type of miscarriage, if you like, where somebody might conceive, but before they even develop anything that can be seen on an ultrasound scan, they have a bleed and the pregnancy ends. So typically it's the person itself, if they hadn't done a pregnancy test, it would be just like having a delayed period. Mm-hmm. So we think of it as a very early miscarriage before the fetus has developed. You were mentioning abortion.
Mm.
So in the strict medical sense, abortion and miscarriage are used interchangeably.
Mm-hmm.
But when we usually refer to the word abortion, we mean a legally conducted termination of pregnancy. That means when someone chooses not to continue with the pregnancy, and this can be due to social reasons like an unplanned pregnancy,
Mm-hmm.
or sometimes it's when there are medical complications and the woman is not fit to carry the pregnancy, or there's something wrong with the pregnancy and the pregnancy cannot develop normally. And lastly, stillbirth.
Mm-hmm.
So stillbirth refers to losing a pregnancy after 24 weeks.
Mm-hmm.
So it's a continuum. Miscarriage is losing a pregnancy before 24 weeks, and stillbirth is losing a pregnancy after 24 weeks.
I see. Thanks so much for clarifying that, Prof. I think, to be honest, the central thread that ties all of them together is still a sense of loss that people can feel regardless of when it happens. And sometimes when we go through loss, it's often that we feel very alone when these things do happen. Actually, Prof, how common actually is a miscarriage?
We know that miscarriages are far more common than people often think they are.
Mm-hmm.
And it is said that 15 to 20% of all pregnancies may end in a miscarriage. That is something we always make clear to patients, and in a sense it gives them the idea that they're not alone in this, and other people do actually suffer the same fate quite commonly.
And I think, the next question when people find out is, I guess, the most prime of all, which is why. Do we have an idea of why exactly miscarriages occur?
That's a question we face all the time.
Mm-hmm.
In research, we know that at least 50% of miscarriages are due to conditions in the fetus that are either genetic or chromosomal, or even structural. So the fetus may have an abnormality which is either in the chromosomes or the genes,
Mm-hmm.
or it could be a serious structural abnormality, for instance, like a heart defect, but perhaps not yet reached the stage where it could be detected.
Mm-hmm.
So these account for 50%. And the remaining 50%, maybe at least from the conventionally available studies and research, we were not able to tell. But many of them may have, an underlying abnormality that just perhaps has not been picked up or been able to be detected.
Well, I think, this other 50% that, still remains an enigma for many. A lot of parents and a lot of mums in particular, when they do go through this process and find themselves without answers, tend to start wondering whether it's because of something they did. In that case, opening up that whole can of worms, will there ever be a possibility that someone may miscarry because of something that they did, that they ate, that they exercised a little bit too hard? Would there be a possibility?
Well, that's a very good question, Megan, and we get asked that all the time.
Mm-hmm.
And I think I always take pains to tell women that no, they were not responsible for this miscarriage in any way, and there would not have been anything they could have done to prevent it. And that's an underlying theme in miscarriages, sort of getting rid of that guilt. If, for instance, exercise is often well-meaning family members always say that you shouldn't have gone to the gym, but we always tell them if I felt you shouldn't be exercising during pregnancy, I would have told you that at the first visit. And in fact, our guidelines currently suggest that moderate intensity exercise may actually be a good thing to do during pregnancy.
Yeah, I think that's comforting to know that, certainly there are many things that will be guiding, the mums through, even from the first visit itself. Another big factor that people tend to consider is age, affecting, how common and whether these miscarriages occur. I was wondering how much that influences miscarriage, actually.
To be very scientific about it, there is a small effect of age. And we know, for instance, that older women may have a miscarriage risk that is closer to 20%. And in younger persons, it's perhaps 15%. One of the main reasons for this is that women are born with all the eggs or oocytes that they have for their entire life. So the oocytes or eggs are as old as the woman herself. And of course, in the passage of time, there's a possibility of some minor chromosomal damage to the oocytes, resulting in pregnancies that do not have the correct number of chromosomes or that have defective genes. The effect of age is fairly small, as you can imagine, because even older women have a miscarriage rate of only 20%, which is just 5% above the younger women.
Well, Prof, I know you mentioned that, there might be some symptoms of bleeding, pain, sometimes even none at all. And at the same time, some bleeding, some cramping, and some pain is also sometimes expected, especially during early pregnancy. In that case, is there ever, a juncture where you can draw a line and say this is an amount of bleeding that's to be expected versus this is an amount of bleeding that, is more likely to be indicative of a miscarriage?
I think the short answer to that is no. And we always say that the bleeding that the mother is suffering is actually bleeding from the mother. So it's maternal blood. And as you can imagine, a mother can lose quite a lot of blood and still remain clinically well. I mean, when we donate blood, we donate 500 mils and we don't feel unwell. It is also fair to say that when pregnant women have bleeding, it is by definition itself, that is a threatened miscarriage. So while we will not say bleeding in pregnancy is normal, we will say it is fairly common. And at least 1 in 3 women experience that. And as I mentioned to you, the miscarriage risk is 15%. So even if you have bleeding, there's an upwards of 50% chance that you might not end up with a miscarriage. I guess as doctors, our job is to reassure, and the best way to reassure someone who's having bleeding is to get them to come to hospital and have a scan. So for this purpose, at the Singapore General Hospital, we have something called an early pregnancy unit. So women who have bleeding in early pregnancy, instead of having to call up for an appointment, they can walk into our unit and we will always undertake to scan them, within the same day. I think in many cases, this may provide reassurance, but it also helps us to make that diagnosis. And I think people are anxious because they don't know what's happening and they need to know what's happening with the pregnancy.
Yeah.
So that second question we can always answer. We can tell them how the pregnancy is doing.
I suppose essentially the most reliable thing is just to essentially seek out medical attention should you have any symptoms that do concern you.
Yes. And I think women invariably do, because it is difficult not to do that when you are having bleeding in early pregnancy. You'll be so anxious. And how we facilitate that is to make sure they have a place to go to seek that help.
Yeah, that's excellent to know that, there's always a channel for them to come in regardless whether or not they have an appointment. Yeah, I think, we're moving on to the next part, which is essentially the overwhelming situation in which you receive the news that you unfortunately miscarried. I'm aware that there are many, many options and many steps from then on. I was wondering, Prof, if you could just take us through what's the process that happens thereafter.
I think the first thing we do is spend some time explaining that it is a miscarriage. And remember, this is not always easy. We have now ultrasound cut-offs where we can tell someone whether they truly have a miscarriage or not. Sometimes we can't, but in a clear-cut situation, an example of such a situation would be, say, we've seen the baby's heartbeat a couple of weeks ago, we see her again and there isn't a heartbeat. So in that kind of situation, we focus first on telling the patient how certain we are of the diagnosis. And in that particular situation, we'll say, we're certain it's a miscarriage because you had a heartbeat before and now we don't see the heartbeat anymore. And then we spend a little bit of time emphasizing to the patient before we even talk about what we're going to do next. We spend a bit of time telling her that she did not cause it. Mm-hmm. And I think that's an important message to get across straight away. We may sometimes differ what we need to do about the miscarriage to a later date, but if the patient is ready, then we will talk about some options. But I'll launch straight away into the options.
Sure.
And the good thing about these options is that it appears if you have an early miscarriage, and by early I mean in the first trimester prior to 12 weeks, all the options have similar long-term outcomes. So from the most conservative sort of option, one could choose to do nothing. And in medicine, we call that expectant management, right? So we just watch. And the reason for that is we know a lot of people, if the pregnancy stopped developing, you've suffered a miscarriage, if you wait, then eventually the woman will be able to pass out the pregnancy on her own. So that's the most conservative option. Some women choose it because you don't have to go for surgery or take any medications. That's the plus point. The slightly frustrating point is we don't exactly know when the miscarriage will happen. And in some women, after they've waited for a little while, they might get a bit frustrated and take one of the other options. I would typically allow women to wait 2 to 4 weeks, or even longer if they wanted to. It's been shown not to be harmful.
Okay.
The second option would be what we call medical management. So we can use tablets or medications to induce some contractions and so that the pregnancy can be passed out more quickly. Many women now choose this option because it doesn't involve surgery. It's faster than waiting naturally in many cases. And if I just touch briefly on the third option, it's what we call an evacuation of a uterus. But what it means is it's a minor surgical procedure where we give the woman an anesthetic, put her to sleep, and we remove the pregnancy tissue. So that has the benefit of being quick, and so you stop bleeding the fastest, but the disadvantage of requiring an anesthetic. So it has to be done in hospital.
So I guess to summarize, essentially, it would just be either one, just essentially watch and wait. Number two would be taking the pills, which is the medical management. And finally, the small procedure, which is basically a small surgery.
Absolutely, yes.
And actually, Prof, we've been taking a little bit of a medical lean to our discussion so far. And you had very briefly mentioned this concept of being able to talk the moms through, the sense of guilt and essentially reassuring them that it is not their fault the moment that they find out about this.
Yes.
I was hoping to have a sort of deeper discussion to the emotional impact of miscarriage. I was wondering, for mums who might be feeling this way, is it normal for them to feel as though, to carry this guilt with them and to feel as though this was their fault?
Yeah, I think the feelings are very different from person to person, but you did mention guilt. There's that sadness, the grief, right? And I mean, sometimes as doctors and obstetricians, we are guilty perhaps of downplaying that a little bit. And I always explain to patients that we have a different perspective of miscarriage. And it's because we see someone have a miscarriage and then in a blink of an eye, we see they've got 3 kids, right? Because we see them get pregnant the year after and then the year after that. So I think the first thing to say is that having a miscarriage does not color the rest of your reproductive life. Meaning it has, in most cases, and I would say in almost all cases, no impact on your subsequent pregnancy. So you have the same chance of having a healthy baby, a successful pregnancy, the next time you get pregnant as anybody else, right? So that's an important thing. But I think we need to also validate that loss. So I think we have to allow them to grieve, okay? But I think it's time that heals that really. So I think we often say the physical recovery after miscarriage is quick, but the thoughts, the grief may linger longer than that. So, so we make sure they have enough time. And I think from person to person, they differ. Some people take longer and some people take less.
Well, thanks so much for that, Prof. I think definitely you touched on certain points like this concept of loss and grief. And sometimes I feel as though it's a very complex relationship with, this unborn child or this child that you never met, given that, our classical understanding of grief is always of someone you've had a relationship with for a long time, especially in earlier miscarriages, for example, 5-6 weeks. At that point in time, if all you have of a child is an ultrasound photo as well as maybe, maybe in a glimpse of their heartbeat for a short, maybe 10 seconds. I was wondering how you personally have felt in your, years and your experience, how you found is the best way for you to navigate and support your patients who feel as though their grief might be invalid because they've never actually met or held this child.
I think the first part of that is recognizing it and giving it some validation. That means saying, I know how you must feel. It is a loss. We have to acknowledge it's a loss. We must refrain from saying things like it's just a miscarriage, because to that person it's no different from losing a pregnancy perhaps later on, maybe even losing a newborn child, apart from the fact that you don't physically see the child. So recognizing that is the most important thing. And I think that goes a long way towards the recovery process itself. For some people, it helps to know what they can do next. I try not to talk too much about the next time because, at least in the immediate period, but I think that kind of belittles that loss. Like, let's just go on and have another baby. And it's not exactly that she's grieving that baby that she's lost. So, but I think if you add the perspective that, there are good things to look forward to, again, not to belittle that loss, but to sort of give an explanation as to how this may not be the worst thing that has happened to them.
Yeah, thanks so much for sharing that, Prof. And Prof, you had made several mentions to the next steps and, how it might affect subsequent pregnancies. I was wondering if you could touch on that really quickly, because I know you've mentioned about how, subsequent fertility isn't really affected by miscarriage, just say if you have one. I was wondering if there were any instances in which, people should be maybe slightly concerned about subsequent fertility as well as pregnancies.
The fertility should never be a concern because having had a miscarriage effectively means you are fertile. So that's something we tell women. Medical sort of science dictates that because miscarriages are so common, if you've had one miscarriage, no special testing is needed. And the assumption is the next time you have the same chance as anybody else and you just go ahead and try. If you get 2 consecutive miscarriages, while that is still possible by chance because miscarriages are quite common, our guidelines currently propose that we do some tests to exclude factors that can cause recurrent miscarriages. That means to make people miscarry again and again. By no means is that the most likely thing to find. Even when people have had 2 or 3 miscarriages, a good number of these women will not have had anything wrong. And I put it very simply to them, it's bad luck. All right? You can have 2 miscarriages and have nothing wrong with you.
Okay, thanks so much for sharing that with us, Prof. I guess part of the next step we also look into is the concept of trying again. Because you had done, very briefly mentioned about that just now. I guess point blank, if someone has gone through a miscarriage, when is the earliest they'd be able to try again for pregnancy?
There is the cultural belief that you must rest the uterus, and all the races in Singapore tell us that. We're fortunate that we have medical evidence that doesn't make a difference. You can start trying as early as when you stop bleeding. Okay, so we often tell women when you stop bleeding, you can start trying. The only problem with that is you won't know when you conceive because you haven't had a period yet. And some people are fortunate enough to conceive even before the first period comes along. But there's also a group of women or some couples who want to take a break, and that's absolutely fine also. They said, we've been through a rough time, we'd like to take 3 to 6 months and rest, and then when we're ready, we'll start trying again. So I think the message is you don't have to wait, but if you want to wait, that's not a problem at all.
Yeah, I think it's certainly nice to end on an optimistic note to know that, essentially they're free to try again and that it's medically safe for them to do so. I guess my final question to wrap up, Prof, is that, it's quite a large question, but just in general, from your perspective and your experience so far, what's the largest myth about, miscarriage that you hope to debunk?
We already went through how it's not your fault, all right? And I think that's a myth. But since we've already discussed that, I think the other one I'd like to discuss is the fact that that you realistically could have done something to prevent it. Okay, and I think the most common prescription you get when you turn up to a doctor and you're having a threatened miscarriage is you get given hormones to consume. Women always feel guilty if they end up with a miscarriage that I didn't take the hormones early enough, I didn't take a high enough dose of hormones. And the evidence for this is very clear, at least for most cases, that there is no evidence that giving hormone support to prevent a miscarriage actually works. So I think we often prescribe hormones, and because we want to give as much opportunity to the pregnancy to develop, and when there isn't a lot of scientific evidence, we want to we always say, give it the benefit of the doubt, even if there's a small effect. But big studies are quite clear on that with the exception maybe of a small group of people that have recurrent miscarriages, for most people who are having bleeding during pregnancy, hormonal treatment doesn't seem to make a difference.
I see. Well, thanks so much, Prof, for your time as well as all of the insight that you've provided us so far. We know that, this is a very, very difficult conversation to have, but it's reassuring to know that, there are people like yourself who are essentially there to always reassure the mums about not only their next steps, but also to essentially hold their hand and support them through what is, at the end of the day, a very emotional journey of loss and grief.
Thank you very much, Megan. It was a pleasure. Thank you.
And with that, we've come to the end of this episode. Once again, this is Megan from the Girl Talk podcast. We hope you've enjoyed this episode. Thank you. Hi, thanks for watching this episode of Girl Talk. If you enjoyed it, feel free to like, subscribe, favorite, and follow Girl Talk on all our social media platforms. We hope to see you on our next episode.